Such a pleasure to be here at Mount Sinai and to be able to contribute very humbly to this amazing meeting. My task is not going to be easy. Again, after these 6 beautiful cases that rotablator is like water here, I have to talk against the liberal use of rotablator and ablation in our daily practice. So again, I think Dr. Singh already won the debate. I have no conflicts regarding this presentation. I think we all agree that calcium is something that we find in our daily basis. This is data from Syntax. You see that at least 50% of complex multivessel disease cases will have a significant amount of calcium. So this is not trivial, and we have to deal with that in our daily practice. And we know that excessive calcification can make the stent deployment very, very difficult. And this is certainly the most common cause of underexpansion of these devices. And sometimes we have to retrieve a crushed stent when we cannot deliver it properly, not to mention that we can damage the polymer of DS platforms if we don't do a good job preparing the lesion. But again, despite this very experienced center with excellent results with ablation, we have to understand that in real life, rotablation have some important limitations, such as the learning curve. Here seems to be very easy, but in hands that are not used rotablator every day, we can have some limitations, complications, cost effectiveness. There is no good trial that tell us how cost effective are these adjunctive devices. And of course, we don't have very convincing data to support the routine use of ablation. In experienced hands in this randomized trial called ROTAXUS, balloon followed by Taxus versus rotational atherectomy followed by Taxus, you see that there was not much difference in terms of complication, one versus the other. However, we have some complications that are not trivial, and for instance, perforation can happen as close as 2% of our cases. And again, with not experienced operators, this can be even higher. So this is an example that we did last week in São Paulo. This is a very non-dominant RCA, and nobody's going to debate that this is highly calcified vessel. This is an elderly patient, such as the ones that you saw before. So there is a little bit of a curve, but very calcified. So we thought that we would go ahead with rotation atherectomy to start with. And again, tight lesions and multi-lesions in this LAD. So we went very gentle with a 1.25 burr. And immediately after ablation, this is what we found. So there was this massive perforation, so we had to deal with that. We did echo, and there was a lot of effusion here. We had to do paracentesis. So it's a dramatic situation, and sometimes if you are not very experienced, it's hard to deal with these patients. So after prolonged inflation, we are able to stent, and after draining the pericardium, the patient did well. But again, if you're not super experienced with this kind of complex lesions, you might experience some of these nightmares. So this is a phrase from my friend Roberto Botelho that he says the impact of the highly improbable. When you see, for instance, and collect the literature, there is a lot of selection bias in most studies. There's limitation with fluoroscopy to grade calcium. Severe calcification is missed in at least half of the patients if you only trust angiography. And the big question is that, do we really need to treat all calcified lesions with ablation? Or we have to select the ones that will keep us in trouble, that will give us trouble? And when we look at IVUS data, this was published by Gary Mintz many years ago, and I'm sure that Roxana helped to collect this data. We understood also that if you have deep calcification, such as in these cases here, that angiography cannot differentiate, I think that the burr is not even going to touch the vessel wall, and the massive plaque, the plaque burden, is in contact with the IVUS catheter, and again, ablation will not do a good job. On the other hand, when you have more superficial calcium, as you see in this frame here, this is the kind of patient that will truly benefit from ablation. And again, this is the paper that I mentioned, the poor correlation between IVUS and angiography. Only when we have massive calcification that the two methods agree in 85% of the cases, not to mention the superficial versus deep, that our angiography are very, very limited. So going back to ROTAXUS, the use of a rotablator for sure, and I mentioned that before, improves our acute result by a much better acute lumen gain. However, there is no late impact of using ablation versus the old PCI technique. So keep that in mind. It might get us free of troubles to start with, but at the long term, there's no real impact. So that's why this is one of the reasons why it's very difficult to support the liberal use of ablation if we're not cost effective at the long term. And by saying that, this is the data that we collected recently from Eurointervention 2015, the rates of ablation used in Europe. So the adoption, as you see, is poor, not the 22% that you see here in Mount Sinai, but in real world, as I mentioned, is no more than 3% of the cases in Europe, and for sure in other countries such as Asia and Latin America is not very different. Another randomized trial is called COBRA, and what I learned from this trial is that only 4% of the patients that were randomized to PCI, to balloon PTCA before stenting, crossed over to rotablator. So perhaps this is the number that we actually need in real life to indicate rotablator, less than 5%. This is another study explaining the mechanism of failure of balloon and in the indication of ablation. In 40% was inability to cross the lesion, in close to 60% was the inability to expand the lesion. And the good news is that 99.5% of these patients were successful at the end of the day, at the end of the procedure. So this provisional approach is not a bad one, since we're going to have high rates of success. And this is another example from our practice, calcified, and an elderly patient, very calcified RCA. You see, this is not a stent. These are all calcium with this stenosis at the middle portion. You see the 60–70% stenosis, but very calcified. In another projection, you see that you have more stenosis, as you can appreciate. So in this case, I thought about doing rotation atherectomy, but I decided to give a try. So a couple of balloons, and we had a good expansion. You see a little bit of a dissection, PTCA effect, as Antonio would say. And it's a very good expansion with good stenting after all. So I didn't use rotablator in this patient. However, in this vessel. However, the same patient had this tight stenosis. I was afraid to use ablation in this aneurysmatic lesion here. But I went with a number of balloons, of different pressure, nothing happened. There was another lesion here, but this was the tight one. This one was easy, but the distal one was very tight. Again, lots of predilatation, and we decided to go with rotablator, as you can see here. So this is an example of a provisional rotablator. In one vessel, the same patient didn't need, but the other vessel, yes. So this is after more balloon dilatation with a very good result here after stenting followed by ablation. So we cannot say that rotation atherectomy is the only player out there. You have many options that we have been discussing during the past few cases, and particularly for orbit atherectomy, this is the new device you saw in one of the cases. I think that this is perhaps one of the most robust clinical trials that we include 2,000 patients randomizing orbital atherectomy versus conventional balloon angioplasty. And I think that we're going to learn a lot as we're going to evaluate the primary endpoint of post-PCI in-stent, minimal stent area, but most importantly, the one-year target vessel failure. And to finish, the guidelines currently in the US and also in Brazil will recommend rotation atherectomy as a reasonable device when you have very calcified lesion that might not cross with balloon catheter or will have underdilated devices. So this is 2A. So, and the guidelines support this provisional approach, and they do not recommend the routine use of rotablator. This is, again, US and Latin America. This is my final slide, and I'm following Mount Sinai recommendation when you see a patient with calcium by angiography. If it's mild, you're certainly not going to go for this more invasive strategy, more aggressive strategy. Moderate, you can use IVUS or OCT to guide you and to anticipate which patients will benefit the most for rotational atherectomy or any ablation device. When you have very severe calcium, despite the recommendation to go ahead with rotational atherectomy, I would say that I only use when I have a failed to cross with balloon or when I anticipate any big under dilation or under expansions. Thank you so much for your attention.